Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
Hey, Lesley.
Hi.
So today I am without Jo again. She's on a prolonged vacation. I think she's visiting grandkids. So I figured, because we've been on this kick for a while, talking about good energy and mitochondrial health and the cascaded dependency and all that, with your unique background as a case manager, I felt like this would be a really great opportunity to help equip patients and families when they do have a loved one in the family, in the hospital, to help navigate some of the challenges that are there. So without further ado, here's Lesley Williamson. Give us a brief bio on you. Like, what's your background? How did you get in case management? What are you doing now? Yeah. Who's your favorite boss?
So I'm Lesley, like you mentioned, and I'm a nurse. I'm a second career nurse. So I started 14 years ago. My foundation is ER trauma. I worked at a level 1 facility and went into case management. So I have an undergraduate in theology. I don't know if saying it faster makes it shorter or not.
That's good. It's all a good story. Yeah.
And so I married those two, right? That social justice background with my critical care. And it was a wonderful 7 years that I spent in an acute care hospital. I had a leadership position, and when I came into nursing, I wanted to have more than praying hands. I wanted healing hands too. And when I left the bedside, I wanted to be able to navigate for patients. And that's what I did for 7 years. I learned resources and management of care and all kinds of navigating for patients towards things to help them on their wellness journey. And now I work for the best boss ever with Nexus
awesome.
Home Healthcare.
So one of the challenges you guys have as case managers, and I learned something different before we go into like some of the challenges that are present in hospital situations, but you had mentioned, or I learned from you, that there's a difference in case managers in a typical fashion, right? In a typical world at a rehab or a skilled nursing facility versus a hospital. What in a general world, in general speaking, what are the major differences between those two? Yeah,
I'm still on what I'm calling my world tour. So, being in those four walls of the hospital, I only have a certain view.
Sure.
So it's been kind of neat to get out and see social workers and case manager outside of the hospital and learn a little bit more. But in the hospital, an acute care hospital, their main focus is to diagnose, treat, and to stabilize. A case manager's job then is to look at your progression through that continuum of care, to identify any barriers to discharge with that care or treatment plan. And then we're looking at what is the appropriate next level of care, what's that next step, and making it happen if we can, within the walls and boundaries of our healthcare system.
Sure.
So in a skilled facility or rehab, I haven't ever done that job, but what I do see is that they are very, their job is a lot of regulatory base, and it's a lot of discharge planning. So it's the same kind of focus of getting a patient through the continuum, but it's also about getting them home. Every single level of care is about getting you home and to be successful.
Right.
And I always put the pressure on the case managers and SNFs or rehabs to be the ones who are going to fix those long-term problems. Whereas I always took the out in the hospital that we were that next step to get you towards that
you're the
goal.
interim step. And so in an engineering context, you would see that the discharge plan, whether from a hospital or from a rehab context, the discharge plan is more like the output. Like, this is eventually that we're going to spit the widget out on the back end of the engineering process. And it sounds like and I'm not trying to minimize what's happening at the skilled nursing facility or rehab level, but it seems like more of the focus, with a lot more patients, by the way, more of the focus is more on the discharge planning home. Whereas in the hospital, it's also the discharge planning to whatever the next level of care is. But while they're there, you're actually also focusing on the throughput. Like, you guys are helping to manage the care while in the facility as well. Is that correct?
Correct. Yeah. Okay. Nurse case managers wear a lot of hats. So our day is riddled with meetings, just like anyone with a kind of manager title. We don't have a supervisor or manager position per se, but what we are managing is that care continuum. So it takes a special kind of nurse to be a case manager. I always love when I identify bedside nurses that kind of see that whole picture is what I would call it, right? They're not just looking at what is the medicine I need to give and what time, what is the charting that needs to be done or the intervention, we would say in nursing.
Yeah.
But they're also looking at, hey, this patient has this going on at home that could be a barrier to them being successful in the home, and identifying that, but not just knowing it, but also passing it along. And so a nurse case manager in the hospital will also, part of those meetings are what we call rounding. Interdisciplinary rounding is a really big thing. It's part of a successful throughput in hospital systems to get patients through. And it's not a lot of people think that we're, trying to kick you out of the hospital. It's not that, right? Again, we're diagnosing, we're treating, we're stabilizing, but our other job is to make room for that patient who's coming in with an acute problem that can't be taken care of at home or another level of care that we have to have a bed for.
Yep.
And that's where you get that backup sometimes in the ERs, which is a really dangerous situation, or even just a high census in hospitals to begin with that make them shut down. So then they can't bring patients from hospitals that don't have those same resources.
Yep. Well, then you have patients staying in an acute setting, which we've talked about before, is very appropriate for a certain period of time for patients.
Yeah.
But once you're kind of past that, once you're more stable and it's just kind of for observation, you might actually be better off in a different setting.
Absolutely.
That makes where it's actually better. I wouldn't say better because that's not a good way to put it. More appropriate care for the stage of whatever condition you're dealing with, right?
Yeah.
So it could be a rehab hospital where they're getting up more frequently during the day, where the hospital is really not set up for that kind of intensive up and down, getting them around the room, transfers, gate, whatever. And so just by getting them to where we can get them to the next level, it actually opens up the doors for the rooms for additional people that might need that specific level of care.
Exactly. Yeah. A lot of times people, I think, we're getting through that generation of patients who were in the hospital after surgery, told to lay still for a week, laid in the hospital.
I know.
And there's a lot of teaching that happens. I mean, we still see patients as nurses who remember having actual needles in their arm when it's a plastic catheter now, and they can bend their arm. And so a lot of teaching with that generation. And as those move along, we'll be able, I think it'll change, right?
Yep.
Because our healthcare system is set up this way. The acute care hospitals do one thing. And then, like you mentioned, we move them to the appropriate care so that they can continue the treatment if they can't go home.
Speaking of home, I know when you're looking at discharge planning, you can look at a variety of different settings for them to go to: rehab, home health, home hospice, skilled nursing facility, whatever. The home environment is invisible to everybody except for the patient and the family. So how does a case manager figure out what resources are needed at the home site, given that they can't see it?
Yeah. This is where it takes that skilled nurse, right? That one that sees the whole picture. It helps. I think it's really unique in case management to have bedside nursing experience. So I love hiring, or I did love hiring bedside nurses to come and work for me in case management. I had to start from ground one, but at the same time, they could speak the language, knew how to do medical assessments and things like that. They really stuck out to me. I forgot the question.
How do they determine, given that the home is invisible to the case management team, how do you make sure you get the right stuff to them? Or them to the right setting?
Right. So I'm going to miss the actual case management assessment, like the whole thing, right?
Yeah.
But I think that there are some important things that I always taught case managers to ask when they were in the room. And again, we're only getting the version of whatever the family or patients let us know.
Yes, because newsflash, there are patients who hate being in the hospital and they're coming home. So they're not about to tell you about the 3 steps down to their sunken living room or the doorway to their bathroom that's only 12 inches, wide and they can't fit a walker through there because they want to go home. Like they're going to shade the truth in a way that benefits wherever they're trying to do. If they're trying to stay there longer, they'll shade it that way.
For sure.
Yeah.
And that's that loss of independence, right? Or the fear of it. As a senior member of our community, coming into the hospital is one step closer to losing that independence or your family losing that faith in you to be living independently. So there's some key questions that we ask, where do you live? Do you live at home or at an assisted living facility? And that's going to give the direction for me to ask what resources that you have at home. What is your support system? Are you this giant, senior on a walker with this tiny woman or tiny spouse taking care of you, and that's a whole nother issue that we can get into. But that pressure that we put on our caregivers to maintain that independence, we're going to ask what equipment that you have at home. And what your functional baseline is with that equipment. Are you getting up and going to the bathroom? That was always my criteria in the ER. Because if you can't get up and go to the bathroom, do you have something to help you like a bedside commode?
Correct.
Can you even transfer? If you can't, that's not a safe discharge, That's a little bit of a stretch, I think. But that was one of the things,
I think that's a fair, it's a fair high point of something to hit. This is going to happen 7 to 10 times out of your day. Yeah. How are we going to manage this? Right.
And so the other things that we look at besides that are, do you have access to meals and food? And not just access, but are you capable of getting to the fridge, making that, meal? Is it nutritional? Are you always eating out? Any resources that you have coming into the home from the community, we're going to take note of, because if you don't, and we identify a barrier to discharge, we're going to try to hook you up or navigate towards something that could be helpful for you. I always miss things because, we've got our system in front of us that kind of give us that log. Sure. I'm running through it in my head here.
Well, so I'll give you, for example, when I used to work for a research company, and they had done some long before I'd gotten there, they had done some research on, there's a set, like a standardized set of scoring tools that they use at a lot of skilled nursing facilities and rehabs. And so they looked at that way of scoring a patient in a facility. Right. And then they took those, and as the patients were discharging home, they then rescored them based on their current home environment. And so what they found was there was almost no correlation in their ability to perform certain, what we call ADLs or IDLs. So things like transfers, things like home mobility, things like getting up and out of bed, dressing, all those kind of things in a hospital or a rehab or a skilled nursing facility based environment. It's all ADA compliant, because you'll be shut down if it's not ADA compliant, right? You usually will have, a high-low hospital bed. You'll have access to all the greatest equipment that's there, right? The bathrooms are nice and wide. The toilets are elevated. There's usually a walk-in shower with a bench to sit on. If you needed it, there's a bedside commode. There's all these things that may or may not be existing in your own home. And so what we found was there was very little correlation in the scores of someone's independence at a facility versus in their 1970s home with the sunken living room, the narrow doorways, and the barky cat, or barky cat, just caffeine, the barky dog. There's all these other risk factors that were not present in a hospital environment. So I can imagine even best effort, trying to go through a checklist of, hey, tell me about this, tell me about this. The therapists who work on those functional aspects, like in facility levels like that, are still limited in being able to impact that, from the facility, because you just don't know exactly what that home's going to look like until you watch the patient actually navigate the home. So you're trying to do the best you can through asking questions. Tell me what it looks like. Are you able to get in and out of the bathroom? Can you get your walker through the door, or your wheelchair, or whatever? And
I can only work with the story that the patient's telling me.
Correct.
And as a case manager, a load on a med surg floor for nurse to patient ratio is sometimes 6-1, which is a lot, right? But the amount of time that they're spending with that patient is way more than someone like a case manager who's carrying a load anywhere from 20 to 30 patients in the hospital. And that's why I briefly mentioned rounding earlier, but I want to go back to that because interdisciplinary rounding is so important. A case manager is just that. They are a manager, or a care coordinator is the same kind of position, just called something different. Yeah. But we are taking in all of this information, right? So not only our brief assessment that's less than, probably less than 5 minutes in the room, of going through these questionnaires, and you're only as good as your case manager is experienced, right? And picking up on what the story is, or nonverbal things, or looking in the room. Hey, there's a walker laying there. Let me ask about that. Right. But it's really important that a case manager is very good and has bridges of conversation built in with their interdisciplinary team. So physical therapy, respiratory therapy, dietitians, I don't know what else, occupational therapy, speech therapy, doctors, of course, because that's where everything trickles down from. And so all of that sometimes will get picked up. And again, it's important. Those roundings aren't just to give information, but it's for a case manager to also teach that interdisciplinary team what we're looking for, what to concentrate on. There's a finite amount of barriers to discharge that we're looking for to identify in a patient. So that functional status support, can they go home and function at the way that they're saying their baseline is when you assess them. And I put a lot of faith into that physical therapist or occupational therapist, speech therapist, into telling me, hey, yes, they can. But on my world tour, I'm realizing... It's what I've been calling it, outside of the four walls of the hospital, I'm seeing all the sides of healthcare where I've sent patients or, been under these illusions that I could tell something, or even just now when you said that, they only can see so much, do so much, and then it's completely different when they get home. Right. And it's a privilege to go into the home. So it's why I'm part of home health now, It's ultimately where they have to go to be successcul, right? And so it's the one place that nobody else ever gets to see outside of maybe house call doctors, right? If they're visiting them there. And so it's crucial that we get as much, develop as many insights as we can in that patient's world at their home site to kind of see what are the things that are ultimately going to affect them. But it's hard when you're doing it from someplace remote, rehab hospital or a hospital in general. Yeah. What do you, and you mentioned a couple times, because we see it too, because I'll be a therapist on a case, I'll have a nurse on a patient with me, and we think we're asking very similar questions, and we get very entirely different responses. Yep. So how did you, and again, same thing, the narrative that they want to sell you on is, I want to go home today, I'm ready to go home today, or I'm not ready to go home, I need to be here longer. And so you'll see how that may bias their responses back to you when you're trying to ask questions. How did you drive effective communication with that? How did you kind of ferret through some of that stuff? And how did you, because I'm sure there's underutilization of some resources that are happening, because maybe due to ignorance, they don't know what the benefit of these things are. How would you navigate those conversations with patients and families at a time in their life where everything seems high stress, high anxiety? It's really hard because we take for granted in nursing, it's all about trends of care. One low blood pressure, we don't respond to, right? We're going to take 2 or 3 more, see if it's a trend of vital signs, and then, respond to that. And so I don't want to say that every patient fits an MO. Correct. But they do. Stories don't differ on a general baseline in the hospital. There are a finite amount of diagnoses. There are a finite amount of barriers to discharge. So when you hear that story, what I'm looking for is that negative, right? So you're fitting. Oh, now you're not. Yeah. Okay, that's a trigger for me. What resource do I need to be giving to help you be successful.
Okay.
In wading through, it's a grief process. So I also had to be aware of that. How do I explain this vast healthcare system with black holes in it of what's your next step? And there's sometimes where I had to say, I don't know,
Yeah.
Research tells me that the longer a patient stays in a facility, the more issues they're going to have.
Correct.
And so I would explain that to them.
By the way, they also say that if you go to adverse events, 25% more likely to have an adverse event if you went through the ER first and then to hospital. So probably another one of those things, it's extended time in those walls of a facility.
Right.
So we got to make decisions quickly. Yeah.
Yeah. And speaking of decisions quickly, so a lot of case managers that I would train would get caught up on that waiting to have a plan, right? I'm going to walk in, make an assessment, and we're going to plan right then.
Do you base that off of what their previous level of function was?
Yes. Yep.
Okay. And severity of diagnosis, whatever dealing with now, right? So if it's a major stroke, obviously things are very, very different.
And I'm going to listen to families to home is the goal, period.
Yes. That
is where a patient is supposed to be the safest if we can set them up with the right resources and things like that. Forgot again what I was talking about.
We were talking about communication with family members. Like, and how do we effectively communicate with them? What are options?
Yeah.
Why are some certain things like home health being underutilized?
Yeah.
Is it an ignorance thing? Is it just a confusion thing?
Mm-hmm. I think it's a knowledge thing. You see a lot of families that have had bad experiences. Let's don't even go into hospice conversations, right? Like that's a whole nother show.
It's a whole other level of anxiety with that too,
level of anxiety,
though, right?
For sure.
Like it's kid gloves. Like you have to remember we're in this weird healthcare space where it really is, we're waiting on something bad to happen to somebody before we have our jobs and our paychecks. Like it's a really effed up way to kind of see that industry, but it's kind of where we are now. So it's not, that was really bad.
Good. I'm glad it's not just me this time.
We'll leave that. But it's really, because I get a little bit irritated with it because it is one of these things where our jobs kind of rely on people being sick and injured. Strange, right? And so in various levels of care, at the hospital environment or within a home health or even hospice, so hospital, hospice, and home health, skilled nursing facilities, rehab's the same thing. Like you're dealing with people whose bodies are already failing or have failed at this most recent time. There's usually family members involved who, hopefully there's family members involved. It's a much harder challenge when there's no family members involved. But when there's family members involved, they're also on high stress, right? Yeah. They're usually adult kids with their own kids, in high school or college or whatever. So they've got their own careers, and then mom and dad are fallen. So there's all these things, and every decision has to be made
right then.
Quickly. And so I think a lot of, at least my personal experience has been, a lot of the failures has really kind of been as a root cause is we don't understand the level of empathy necessary to help those family members through that. And I think if we started it with, if I were going through the same thing, how would I want somebody to communicate with me? Yeah. I think the rest of the processes would kind of fall in line. At least that's at least my opinion, and I think we've done a good job with our company of like starting with that and then kind of working through how do we solve for that. But I think a lot of it's just maybe not a disrespect, but just not understanding the level of anxiety that's happening with patients and family members as they're kind of working through this. And some of them, this is the first time they've ever gone through these things. And so this is where like having really effective case managers at the hospital level to kind of navigate and go, hey, here's what the ultimate goals are. Not we're saying this to you, but you're communicating to us. Your ultimate goals are to go back home. Like here's the barriers to coming back home. Here's some interim steps we might be able to take to do there. There's probably some equipment needs that we need to have. And then there's probably some resources we need to bring into the home, PT, OT, speech, whatever, private duty caregivers, whatever, to help make that work. So I would imagine you guys, there's a lot of psychology at play when you're having to sell them on something. I say sell them. When you're having to sell them on the idea, at least of, hey, there's other things that need to happen. I know you're ready to go home and you're excited to get the heck out of here, but you might need some help with these things.
Education is key, right? So it's hard as a case manager. We're constantly going, keeping up with what we're doing during the day, lots of meetings, lots of communication. I was fielding like 150 to 200 notifications a day on my phone. Look at your phone and see how that compares, right?
Try going to 0 notifications on that one.
Yeah, I thought my phone was broken when
Golly, that's a lot.
So juggling all of that communication, but also making time to talk with families. So a case manager is only as good as their experience. A nurse is only as good as their experience. And case managers that are starting in smaller hospitals or, lower levels of care, you're not going to get as much exposure to like complex discharge planning as you would. And so a lot of times they'll say there's not an answer. Well, it depends on the person, right? Are you going to accept that? Or are you going to challenge the system and say, who's the next person I ask? Because I told that to families a lot of time that had issues that I couldn't solve, despite the
magic wand that you have.
The case managers, especially social workers, can solve anything in life that brings to you. But I would say, we're not done until we don't have that next person to ask. Because it's it's the conversations that will lead you to the answers of the person who has experienced it or has that resource for you. Yeah. I think, setting up patients for success, we always look in the acute care hospital setting for that next step. I always challenged case managers to say, if you can foresee what the step after that is, go ahead and set it up. It's going to take you 2 seconds, right? To send clinical or to give information to a family and say, hey, after rehab, this is a home health that specializes here in this that you may want to look at, right? The other thing is being open to liaisons or in-services or CEUs that are offered, whether it's during your workday or after, to be educated on what services are out there for patients, because that's what you're going to put into your tool belt, right? Yeah. And it may not hit every patient or every family or every situation, or you may not need it all the time, but you never know when you need to go into your Rolodex. Totally showing my age there. Go into your Rolodex and pull that out and say, hey, I've got this for you. Like, here's some information. This is the only step I'm going to take is to give you the information. And now you're going to have to bear the next steps of calling and waiting and finding out. And it's a lot on families, and I don't underappreciate that.
What does the patient choice thing mean to you? Like, how does that work in a hospital? Because it feels like there's limited, because you're kind of being directed, right? Yeah. So I learned this when family members of mine have gone through the hospital. Even the family members who are there to help watch over the ones who's in the hospital, you're kind of deflecting a lot of your, I don't want to say, maybe not deflecting, but you're outsourcing a little bit of your autonomy to the experts that are in those 4 walls, right? Because we're not doctors, we're not nurses, we're just there loving on a family member. And so we're kind of letting them kind of take the lead, and we just go, yeah, that sounds good to me. So with regard to that, a patient choice, how does that work? How would you advise family members to take the patient choice thing?
Oh, gosh.
I know that's kind of a can of worms.
It's hard because so I'm not going to try to shade this at all, right? Yeah. In the industry, we want to move you out of the hospital, right? Okay. So do I want you to go take the day or two it takes to go visit all these facilities? Which hat am I wearing? Am I wearing that financial hat as a case manager?
You need somebody out of the hospital quickly, and they want to be out of the hospital quickly, which means you're not going to give them a dozen things.
Right. So we do a good case manager. What's worked for me is that I'll only put maybe 4, right? I'm going to listen. Where do they live? Do I know that area? Have I worked with companies before? And I'm only going to give them a few options. I am going to say you can Google skilled nursing facility, inpatient rehab, if you're not limited to this list, but these are companies I've worked with.
Yep.
Now, knowing what I know outside of the four walls of the hospital, have I really worked with them? I don't know. I've had stories come back, and that's how I put into my tool belt, right? These are companies who respond to problems. That was always a huge one for me. Not, can you not have problems because everyone has problems? How do you respond to it, and how do you fix it? And how quickly do you respond to it? And then what is that feedback from patients that I get?
Right. That's exactly what you're looking for. The feedback loop. You need something to provide a feedback loop back to the hospital. So you guys have,
and what worked for me always was to limit that network of people that I worked with. Because one, they wanted my business. I mean, let's be honest. That's what I'm giving them, right? Whether it's through a list that is supposed to be neutral source of information, I'm still clicking the box to put their name on a list. But I am educated on that list. So I look at star ratings for as good as they are. I look at feedback from patients. I look at, do I have an advocate, meaning a liaison, a DON, someone in that business that's going to respond if a patient calls me and says, I'm having this issue with this company that you set up for me. A lot of case managers don't want that responsibility. It's hard because they don't want to be seen as responsible for setting them up with that company. And we're only as good as what we're marketed or in service or educated.
We have the same issue, right? So we are, and you know this because you work with me for a couple months now. Like I'm ultimately a patient advocate with a PT license, and so I have family members who ask me regularly, like there are resources that we need to connect them with, and so whether it's private duty or hospice or palliative care or assisted living or senior living placement or whatever, and so I understand the hesitation with that. I still take it as like my responsibility. Like they're coming to me and they're asking me for my expert opinion. Who do you know and trust? Doesn't mean that there aren't other ones that wouldn't be wonderful for them. They're asking me specifically, who do you know personally and trust that you would send your mom to? And so I'm very careful, and they're all vetted, because the last thing I want is to get a phone call back from them going, hey, you referred me over to XYZ private duty and they were terrible. Like or the assisted living, that was terrible. So the ones I recommend regularly, like they have a consistently good job. So I kind of take that question as it's my responsibility to help them, because they don't know. This is the first time this family member is going through this. If they've been through private duty before, if they've been through home health before, they're going to know, hey, this is the company I want to go through. The fact that they're asking you, it tells you they don't know. They can go through Google and they can find those, but you and I both know, like reviews are not as...
Only the people who've had bad experiences are taking the time to put those reviews out there, you know? And I think, time is so hard, but if you get a patient who has done the level of care that you're going for and they're ready to give you feedback about companies, take it with a grain of salt, because it's only one experience and you can't ever predict who's going to walk into that room to give the care, right? But you can predict a trend of care. The other thing that I can't stress enough when I trained case managers is you have to give your contact information. You have to. You are the only tether to the hospital that they have when you're setting up these services. Not only that, but to educate them when services should start. It never failed. I would get patients calling me a week later and home health hadn't come out after a post-surgery knee. Right? They need to be seen next day. We just had one of these. I know. It happens all the time. Being asked
to solve it.
Yep. And so part of that education is understanding how those levels of care work. Saying you should expect home health to see you within 48 hours of your discharge. If they don't call you by tomorrow afternoon, please give me a call, because my job is done. I've confirmed your services. That's another thing, by the way. Sometimes we send those case, you know who you are, case manager. You send it out into the abyss, and all of a sudden your job is done. Patient leaves, and did you confirm that services have even an anticipated start of care? Has the patient been accepted? Do they take the insurance? So that education piece with patients is so crucial, because they're going to sit there a week. Complications may set in, and you could have you were supposed to have set up resources for them, but because they didn't know or they didn't have your direct number, they had no one to call. And a lot of times they'll call the floor and they'll say, oh, that's not us. Call the office. You'll call the office and the office will say, that's not us.
Call medical records, whatever.
Yeah. Who is it supposed to be?
Right.
Me.
It's case manager.
That's who it's supposed to be. It is. Because every single patient I took care of was family. Now, could that lead to burnout? Yes. That's a whole nother episode.
Stay tuned for that one. Lesley, thank you so much for joining us today. So what's the best way to reach you if someone were to contact you? If there was a case manager who, hey, I want to learn more on what your process, because I know you trained a bunch of them here.
Yeah.
If there was resources that they have questions for you about, who can you connect me with this person or whatever, or if they have questions about home health or just in general, how would they reach you?
Yeah. I think email's great. So if you want to email me at Leslie@nexushomehealthcare.com, I'd be glad to get back to you. And I'm usually pretty quick about it. If I don't use these resources now that I'm outside of the hospital or my connections, I'll lose them. So, ask away.
Very good. Thank you so much for joining us. This has been a blast. We'll have to have you on again soon.
Thank you.
All right. Awesome.